I kind of made these slides based on the module. And again, I pulled out the stuff that I thought was probably most important for you to know. One of the most important things, and this isn't just for this class, but for NCLEX, for nursing care, all of that kind of stuff, is the idea that pain is subjective. So when you have a question on an exam that asks you, you know, the patient doesn't look like they're in pain, but they're telling you that their pain is a 10 out of 10, believe them. Believe them on the exam. You may behave slightly differently in real life, which I actually don't think is, I think we should believe them. But when you come across those questions, patient says it's a 10 out of 10, it's a 10 out of 10. You treat it like it's a 10 out of 10. There are always questions kind of like that are trying to trick you up. And then, so we have like here that she's got this nice, you know, definition of pain, which is great, but I'm guessing you're not going to have to, you know, memorize that and know it. Understand that it is complex. Again, this idea of subjectivity is huge when we're talking about pain. Did this again. Is the most common reason to seek healthcare. I can attest to this, being in the ER. It like a huge amount of people just coming in, abdominal pain, or because they have no idea what it is, right? And then keep in mind that when you're doing exams and what have you, we're always looking at nursing and patients as a holistic concept, right? So pain as a holistic concept is not just physical. It has emotional and cognitive kind of aspects to it as well. I think probably this isn't that important. I'm going to skip it. Well, the only thing on this slide that I thought was for you guys to know is this here. So because a lack of serotonin can be involved in you know, so serotonin can balance out the pain, right? So having more serotonin is a good thing. We will sometimes give these triptylines, which I'm not sure you guys have gone through yet, but these are antidepressants. They're tricyclic antidepressants, and we give them at low doses for pain. So you'll see a lot of people come in with like migraines that are treated with these triptylines. So just don't get tripped up if you see that on a test. We do use those antidepressants for pain at lower doses. It does come in because of something called serotonin syndrome, right? You can actually basically like overdose on serotonin. So if you're taking a triptyline and an MAOI inhibitor and an SSRI, you can basically overdose. Anyway, sorry, that's probably none of that's going to be on your exam. Maybe the triptylines, but hopefully it'll help you remember things. So really what's important is remembering that pain is a symptom. It's not a condition. It affects your senses, your affect, and cognition, right? Nothing big there that we need to kind of go through. This is a big concept. And it's funny because I find it's a fairly easy concept, but a lot of people get confused and mess up on this on a test. And I think that's because people like out in the real world kind of use the terms interchangeably. So a pain threshold is the point at which you feel pain. Okay, so I kind of made this little thing down here. This is where the person is feeling pain. You've had a noxious stimuli, and then you feel the pain. That's your pain threshold. The pain tolerance is how much pain you can handle before you are needing help, right? So for some people, this space in here is quite big, right? Mine's about this, so I don't like pain at all. But so this is definitely gonna, I would say this is definitely gonna come up on an exam. So make sure you understand the difference. Again, threshold is when you feel it. Tolerance is when you, okay, now it's so much that I can't deal with it anymore and I need help. So classification of pain. So the pain can be either nociceptive or neuropathic in origin. So, and the acute on chronic, we'll talk about that later, but it's going to come up in every single unit and it's pretty much the same concepts every time. So you shouldn't, I think it's like the next slide. We'll go over it a little bit more. So nociceptive pain is the pain that is happening when those pain receptors on your body are activated in response to an actual injury. Something has happened, or sometimes an impending injury, depending how sensitive you are. The neuropathic pain is an injury or a dysfunction in the neurons, in those axons. If you remember from anatomy, the way that those, we'll talk about it more later, but the way those neurons are shaped, and they have those axons, and there's damage there in neuropathic pain, and that can actually cause a lot of different things. We'll talk about it a little bit more, but I did want to break a couple of things down because words come up on tests, and people, it's really frustrating when you get a test question and the only reason you can't answer it is because you don't know what allodynia is, right? So neuropathic pain can present in a few different ways. One of them is allodynia, which is feeling pain without the injurious stimuli. So there are two kind of suffixes that go along with pain. One of them is algesia, right, which is analgesia. We know, we talk about that all the time. Odin or dynia is also referring to pain. So if you see dynia or algesia, we're talking about pain. Allodynia is basically like pain that doesn't have a cause. We're just painful, and that is always caused by neuropathy, some kind of injury or dysfunction in the neurons. You can also have hyperalgesia, which if you break that down, super easy. Algesia is pain. Hyper, we know, is too much. So you can have extreme sensitivity to pain. So there's an actual stimuli there, but you're responding like way more than you should be. And then there's analgesia, which obviously with is the absence of pain, which I think a lot of people think would be great. But if you've treated any patients with, for example, diabetic neuropathy, you know that what they actually miss the, yes. So nociceptive pain is pain that has a stimulus. Yes. We're going to go through it more, but the nociceptors are actually sensing that pain and then passing that message on, as opposed to there's something wrong with your neurons. Okay, we'll go over it a little bit more. So I hope that answers your question for now, at least. So acute and chronic, we've talked about this a million times, but I'm going to go over it again really fast. Acute pain is something that is going to be elicited by an identifiable injury. So something has happened, right? You got a splinter or a paper cut, something. It's nociceptive usually. You can have acute neuropathic pain, but then it often will end up being chronic, because once the damage is there, it's there, right? It's short duration. This is going to be the same for everything we talk about: kidney disease, heart, everything. So acute is going to be short. It's caused by something identifiable. Usually, if we don't treat something that's acute, it will eventually become chronic. And this kind of response, this autonomic fight or flight, SNS response, right, where you have your catecholamine release. I don't know what you guys have taken in terms of, I don't know if you took that in anatomy, but when you have that SNS response, your body releases catecholamines, and that is your kind of, it creates that kind of fight or flight. So you get, this is actually a really good thing to remember, because if you can wrap your mind around what happens in a sympathetic nervous system response, you can answer a lot of questions just knowing, okay, that kicked in. It's going to cause tachycardia. It's going to cause rapid breathing. It's going to increase your blood pressure, dilates your pupils, causes sweating, pallor, urinary retention, and dry mouth. And those are always going to be kind of what happens when you have that fight or flight kicking in. So I don't know. Sorry, it's hard to know what you guys have talked about already. So just that's a really important concept. So if you haven't, just make sure you understand that response in the body in general. And then chronic pain is greater than 6 months usually. It's just a pain that's persisting longer than should be reasonable. It's often unexplained, you know, or whatever's behind the pain, it's not explaining why it's been there so long. It can be episodic, so a lot of people will have flares and non-flares. And I know this might seem like, oh, okay, this is we get it. I find these questions actually come up on exams quite a lot, like having to know the difference between chronic and acute, and people do miss it. So just make sure you have that down, and understanding that chronic pain. So this is that kind of holistic view that we were talking about. Always, always, always in nursing, whether you're doing a nursing care course or you're doing this kind of patho, you want to think holistically, right? So somebody with chronic pain will have difficulty sleeping, and will end up being completely exhausted, and sometimes disoriented, or even like delirious. It increases catabolism or catabolism, or however you want to say it. So it's like metabolism, but this is metabolism that's requiring a lot of energy. It can affect your ability to heal. It affects your immune system, and then can increase your myocardial demand. So this is just from having chronic pain, right? Because we talked back here about this SNS response. When you're in pain all the time, you tend to kind of live at that low grade kind of fight or flight. And obviously it does a lot of damage, or can do a lot of damage to the body. So the nociceptive, we can break that down a little bit more. Okay, so it can be somatic or visceral. This is a good test question. When we're talking about somatic nociceptive pain, we're talking about pain to the tissue, the skin, the muscle. It's part of, if you remember, the sympathetic nervous system, right? It's that voluntary nervous system. And then your visceral, anytime, you guys probably know this, but anytime you see the word visceral, we're referring to organs, right? So that's this is like, I've sprained my ankle, I got a paper cut. This is my gallbladder is exploding, or my appendix is exploding, right? There's a difference. And then we classify, sorry about my slides again. We classify neuropathic by its location. So you either have central neuropathy or peripheral neuropathy. And you guys have seen this again in your diabetic patients, right? So nociception, here we go with the fun stuff. So this kind of will answer a little bit of what you were asking. So nociception is when pain that arises from the activation of these nociceptors. So the nociceptors are just free nerve endings that are found in all of your tissues except for the central nervous system. So I think there's, see, all except for the central nervous system. They respond to unpleasant stimuli. So it's not just pain, it's like heat and cold as well, right? Like extreme heat or extreme cold. But it's a lot like inflammation, right? You get those chemical mediators that are released, and that inflammation and pain are tied together. You'll see that later. But we talked about what causes that pain. You need to have the bradykinin that's released. And you need to have the prostaglandins, right? And that's released immediately kind of upon this, like in this peripheral area, right? Yes, the prostaglandins and bradykinin response does go deeper than that. It goes into the system, but right away when something happens, you're going to get that release of those chemical mediators that's going to cause the inflammation and cause the pain right away. What's important to understand with pain is that there has to be enough, and with nociceptive pain especially, there has to be enough of those mediators to irritate or to cause potential in those nerve endings, in the nociceptors. So the process of going from that noxious stimuli to action potential, that's called nociception. So it's when you've, sorry if I'm repeating myself, but I want to make sure you get, I don't want you to miss out on something easy like this on an exam, but right? It's the process of changing that chemical mediation and that noxious stimuli into action potential, which is the actual depolarization and repolarization of the neurons, the axons. We'll talk about it later, so don't get overwhelmed. But and that's what's sending the signal to your brain and saying you're in pain. Okay, that's nociception. I find this comes up on exams too. That so is that the same thing as transduction? So nociception is kind of the catch-all for that overall process of that happening. Transduction is kind of like the very, very beginning of that happening. We're going to go over it on another slide. And if I haven't answered your question when we do, come back to it, because it's a little bit complicated, but not terrible, I promise. Okay. One of the things they like to throw at you is that, like, you can't see this pain, right? And so, again, I know I'm hammering this, but just the fact that it's subjective, that you can't see this happening like you can see a STEMI on an ECG. You can't see this happening, so you have to trust the patient and what they're telling you is happening, right? Yeah, so I think this might answer your question. So I just want to flip forward because I don't want to say it wrong. Give me a second. So yes, Lichelle. I think maybe the quickest and easiest answer to that is yes. The process of nociception, you're right, is changing that stimulus into a signal, right? That is going to then go. And just, we talked a lot about, inflammation last week. So it's a little bit nice is that you already understand that when something like this is happening, something like this is happening, you already know that these prostaglandins are going to be released. You know what's happening to these mast cells that are releasing histamine. You know where the bradykinin is coming from and the prostaglandin, right? And so right here, this is nociception. This process of, okay, there's enough of these chemical mediators to now turn that into a signal that's going to then go to the dorsal horn and so on. So 4 phases of nociception, definitely important to know these, to understand them. We'll go through them a million times, but you've got your transduction, which is basically what we were just talking about. You have your noxious stimuli that's then turning into action potential and sending the message, which is then transmission, right? Sending the message to the dorsal horn. It synapses here and then crosses over and goes up to the thalamus where you perceive it, right? And then it modulates. The body reacts or responds or does something to it. We're going to go through that like in detail, but it's just kind of a good idea to have like an overview. Oops, sorry guys. So let's talk about the trends. Do you perceive the pain in the cortex? Yeah, so I have a whole slide on perception. It's actually not really clear, not clear to me, not clear to anyone, where exactly you receive it, but yes, somewhere in the cortex. And there's a few details to that. Let me see if I can flip over to, actually it's like 10 slides away, but I will talk about it. Okay, so let's talk about transduction. So this is that first thing, is that nociception we were just talking about. You have the stimulus that depolarizes. The stimulus is enough to depolarize that nerve and then sending the electric impulse. Okay, so we talked about that ad nauseum. I'm not going to keep going, but do you guys remember this from, I'm hoping, from anatomy? I don't know where you would have learned it. This is really important to understand this. So this is your axon, right? This is your nociceptor. This is this whole thing here, right? And inside of this part of it here, this is the axon of the neuron. This is what's happening. Okay. So when enough stimulus has triggered that action potential, this is what happens. So normally the inside is negative. Okay, so this kind of section right here is showing you what it normally looks like, because the action potential hasn't hit this section yet. So it's normally negative on the inside, positive on the outside. We've got lots of potassium in here and lots of sodium out here. Okay, when the stimulus hits, it causes that action potential. It actually makes this membrane on the outside of the neuron or the axon become permeable to sodium. And so what happens is that sodium rushes into the axon, and it changes it from negative. It's not negatively charged anymore. It's positively charged. Okay. So that process right there is called depolarization. And that's because you're polarized, right? You have all positive outside, all negative inside. Now you have the sodium rushing in and causing the inside to be positive. It's not polarized anymore. It's depolarized. When we get to reading ECGs, if we ever get there, this concept is super, super important. If you want to learn how to read an ECG, understanding how the signal is going from your SA node to your AV node through this kind of action potential is really, really important. You don't need to know it right now, though. So this here, depolarization. And then what happens is, in response to this depolarization, the potassium will now rush out of the cell or the axon. And I always just think of it as like potassium and sodium do not like each other. They generally, if one is high in one area, it's low in the other, right? That's why you have so much sodium in your blood and so little potassium. And then in the cell, you have more potassium and less sodium. So the potassium responds by rushing out, and now the outside has turned positive. Okay, so now we're polarized again, right? We've got negative, negative, positive, negative, negative, positive, positive. So now we call this repolarization. So if you look here, this whole section here like shows you before anything happened. This is the depolarization, and this is the repolarization. And that is how that just keeps moving on and on and on and on through this axon. Whoops, sorry, that's the wrong way. Through this axon until it hits here and it synapses to the next one. Okay, and it just keeps going and going and going like that. It takes me forever to explain that, but it happens in like I guess split second. It's so incredibly fast. Action potential. So it always throws me off because of the word potential, right? So I feel like the action potential is just this kind of it has potential, right? But this is actually resting membrane or resting potential. This is action potential. So hopefully that didn't scare you too much. So now we've got that noxious stimuli that has started that action potential, and now we have transmission. So now we're talking about the transmission from that nociceptor that has been triggered and the action potential that has been triggered to the dorsal horn. Okay, so it moves along, it just moves along the neurons to the dorsal root or the dorsal horn, which we'll talk about later. So I won't explain it right now. And then it synapses. You can actually see, you can kind of see here where it's synapsing, right? It's got to jump from this first order neuron to this second order. This is all part of transmission. We're going to take the spinothalamic tract up to the thalamus. So everything from that moment of nociception to the thalamus is transmission. Okay, let's move on because we got to talk about this dorsal horn. So the dorsal horn is just the place where that impulse or that action potential moves from the nociceptor neurons to spinal neurons. So it's exactly the same kind of process, and you don't need to know all of these little, like all of what's going on in here, but it's that exact same concept of it's synapsing. So here you have your nociceptive, the very last nociceptive afferent nerve, and this is the dorsal horn, and it has to synapse. It has to jump, right? It needs neurotransmitters and what have you to jump across. And over here now, this is now the spinal, spinal neuron, and that's going to then go from that spot from the dorsal horn up to the thalamus, and we're going to go through that. I think here there are just a list of some of the neurons that are required to make this jump here. Should we know the functions of each neurotransmitter? I don't think so. Okay, I think that's way too I think that's way too detailed. I think just knowing that these are the 3 ones that exist and that's what they do for this specific purpose, which is jumping from the nociceptors to the spinal neurons. So it's not that overwhelming. This substantia gelatinosa, whatever, is just the area of the dorsal horn that receives that message. So if you look here, these are your dorsal horns. Sorry, it's really hard. I need to get a pen. Those are your horns here. And then inside here, that's what we're talking about. This is the gray matter in there that is actually receiving that input from the dorsal nerve root, and then sending it up. And it's specifically there to receive messages for pain and thermoreception. Okay, so we're going to talk about the spinal thalamic tract a little bit. Again, so should we know how each transmitter goes from nociceptor? No, just know that those are the transmitters that those are the neurotransmitters that are used to jump that synaptic cleft. That's it. Otherwise, you're going into like how action potential becomes a synapse, and I think that's way outside of the scope of this course, so I wouldn't worry about it. Thank goodness. Now watch, there'll be 10 questions on. I'm just kidding. There won't be. So again, so we're talking about this spinal thalamic tract, right? This is the tract that brings that message from the last kind of where it's synapsed here, the last nociceptor, through the spine to the thalamus. That's why we call it spinothalamic, right? It's going through the spinal and going to the thalamus. So it does that in a couple of different ways. This gets a little bit tricky here. Not tricky, but it's where you might have to just memorize a little bit. So there are kind of 2 tracts within the spinothalamic tract. You have the neospinothalamic tract and the paleospinothalamic tract. And for me, I always see neo meaning new. I have no idea, actually. Paleo just reminds me of dinosaurs, and I think it's old. So please don't make fun of me if that's completely ridiculous. But so this is new, this is old. So the neospinothalamic tract is for new pain, right? So it's a sharp stabbing pain. You know the exact location, but knowing that it's specific. Okay, so the neospinothalamic tract, sharp and stabbing, it gives you that specific or exact location of the pain. It's very fast. For example, when you stub your toe, that initial like sharp kind of pain that shoots in right away, that's what we're talking about. But then there's this other tract that's slower. So this one's slower, and this is more of the like deep ache that comes after. Actually, stubbing your toe is probably not a great idea because it usually is over very quickly after the first reaction. But let's pretend that it aches for like, an hour after. That's what this is. That's what this spinal thalamic tract, paleospinal thalamic tract is doing. So it's the slower, it's the deep ache, travels through C fibers, which we'll go over in the next slide, I think. And because it goes to multiple areas of the cortex, instead of just the somatosensory area, it isn't as specific. So it's going to affect more than just that specific toe pain, right? It's going to be more of a gnawing kind of pain that may cause a reaction in heart rate, in mood, and all of that other stuff. Don't get mixed up, because this is definitely going to increase your heart rate, right? You're going to have that SNS response as soon as this happens. But this is just more of a non-specific pain. Are those tracks both for acute pain, or is one acute and one chronic? So they're not kind of separated that way. Like you wouldn't experience this, you wouldn't use this tract for sure as much if you have chronic pain. You're right, you would use this tract. But acute pain is going to often use this neo-spinothalamic tract originally, and then kind of the second wave of it will be this paleo-spinothalamic tract. Yeah, and chronic pain as well, because chronic pain fluctuates and flares. You can actually have, this kind of deep gnawing pain, and then, something will flare or trigger, and you will have this as this. It will use this tract as well. But you're on example of for chronic, you mean? So okay. They're not as separate as I think that you're thinking of them. They kind of work together. So let's say you get stabbed. Let me just clear this. I like that you're thinking stabbed because of my morbid talking about being stabbed last week all the time. So you get stabbed. No, it's okay. It's totally fine. It makes me feel better that I'm not so morbid. You get stabbed. The first thing, we talked about all those things that happen, but by the time it gets to your dorsal horn and synapses over into your spinothalamic tract, it is going to take this first. This happens faster. You're going to get that sharp stabbing pain, but there's a second wave, right? This is a little bit slower. So the amount of time it takes for the message to get from the dorsal horn to the thalamus through the neospinal is quicker. Then, so they've hit at the same time, but the track, this one, is going just a bit slower, right? And so by the time it hits here, you've already had this kind of sharp stabbing, exact specific pain. Now it will dull into this kind of slower, deep ache. So they're not separate in terms of like you only use one. Now, for chronic pain, though, you may have it only using the whatever, this tract, the old tract, the dinosaur tract. You may have that because it's long-term pain. This is usually for acute pain, but you can have what's called acute on chronic pain. So you can have chronic pain and then suddenly have, a flare of it, and then you're going to feel it through this tract. This was in your module, but it's basically saying exactly what I said here. So you don't need to really memorize it or go crazy about it. These are the main points that you need to understand about the two different tracks. Remember back here where we said this paleo-spinothalamic tract uses C fibers, and I said, okay, we're going to talk about that in a bit. That's where we are now. So there are more types of nociceptive fibers, just so you know, but thank goodness for the purposes of this course, they just want you to know these two major ones, which are your A delta and your C waves, okay? And all you really need to do is you can kind of line this up with what we just learned about the neo and the paleo, right? Because in order for something to be, so these A fibers, these A delta fibers, are very fast, and they're the first sharp stabbing pain that you feel, just like what we talked about in the neospinothalamic tract, right? So that neospinothalamic tract is using, likely, not only because there are other fibers, but using these A delta fibers to pass that message on. They are larger and faster. Again, we're talking localized pain. It's specific, sharp, stinging, cutting, stabbing. You have that fight or flight response, and it's a short time. So again, if you can kind of keep these things separated in your mind and know that this is using the A delta and this one is using the C fibers, you should have no problems answering any questions that come up about these different fibers. Okay, so I'll just go over the C wave, right? We talked about the A being fast and localized and sharp and shooting. And then the C fibers, this is your slow wave, your second pain. This is the one that the paleo spinothalamic tract is using. These are the fibers they're using. So smaller and slower, again, it's not specific, it's poorly localized. You've got the dull, aching, throbbing pain. It's more associated with chronic or visceral pain, right? And remember, visceral is pertaining to organs, as opposed to Alyssa's stab wound over here, right? This is slow, chronic. And it's interesting because most pain sensations use this. I think what is most pain is, because this happens so fast, it's over so quickly. Most pain is actually using the C fibers because it's, that SNS is done. So now it's time for this. So if you can kind of walk through what's happening when you stub your toe, burn your hand, or this is supposed to be finger, catch your finger in a door. In terms of the A delta and C fibers, we've just explained that it's going to be the A delta fibers first that are going to transmit that very localized pain and sharp pain. And then the C fibers are going to follow that up with kind of a numbing, gnawing, annoying pain that's going to stay with you for days after you've, slammed your finger in the car or something. Okay. So perception of pain. I think someone asked about this earlier, but it's really not that clear in terms of like where exactly you're perceiving that pain. Some people think it has a lot to do with that, the reticular activating system, which is the system that's responsible for your sleep-wake cycles. I don't think, because it's not, like, it's kind of unknown, I wouldn't worry about, exactly where it's hitting in the brain. Know that you're perceiving it in the cortex somewhere. And then that cortex is going to respond through modulation. Again, never forget that we're talking holistically. So, that perception of pain isn't just going to be the physical feeling of pain. It may have behavioral, psychological, and emotional factors as well. And then there's this sense of needing to escape the pain. So we're not actually sure where it's perceived. Again, subjective. Possibly the reticular activating system. The somatosensory cortex is what's going to localize and determine the intensity and quality of the pain. The limbic system, you already know, right, affects your emotion and behavior. And this is why we can use these cognitive behavioral approaches to manage some pain, because it can kind of not interfere with, but affect the way the person is perceiving that pain. And you'd be surprised, like, the amount of people that can handle very, very intense pain just by being distracted by their favorite TV show or, somebody singing or something, because it does just kind of like affect the perception, right? And where it's hitting here and here. Sorry. Okay. So from there, we go into modulation, which is body modulating or responding to that pain that has hit like hit the thalamus. This gets a little bit detailed. I'm going to go to the next slide. Don't mind my messy like stuff here. Just pretend you. So it's that pain has now gone through those first order neurons, or the nociceptors, right? It has synapsed over to the spinal neurons, which are our second order neurons. We're going to go through all that later. And it has jumped up to the thalamus, and now it's modulating, it's responding. And that's your third order, kind of third level of neurons. The pathway for modulation, it can be a little bit confusing. I actually drew this. The reason it's messy is because I couldn't find a good diagram, and I just kind of drew it out myself. So it starts in this periaqueductal gray area, which you don't need to know like what that is. You just need to know it's in the midbrain. So we're starting in this PAG, which is in the midbrain, right? And what is important to know about the PAG is that it is very, very rich in these endogenous opioids, right? And we all know opioids have an analgesic effect. We'll talk about where that happens a little bit later. It's very, very rich in endorphins. And so it is going to, once it's triggered, it's going to send a message, send these endogenous opioids to this place called the raphe magnus. We'll talk about that in a second. So there's this kind of route to the raphe magnus, and then there's also a signal that just goes straight from the PAG to the raphe magnus. Okay, just so you know, the raphe, again, you don't need to understand like a ton about these things. Just understanding that the raphe magnus is a portion of the brain that is made to respond to pain, and it produces a ton of serotonin, actually. And so we've got this message coming from the PAG this way. We've got a message coming straight from the PAG, and then we have this thing called the rostral pons, which is in the brainstem, and that is also sending kind of a message again to this raphe magnus. I don't think that you need to know, again, you know, exactly where those things are and what else they do, because as you know from anatomy, I mean, first of all, the brain is extremely complex, but each of these areas probably have 20 or 30 different purposes and things that they do, right? So for our purposes, this is really what you need to understand, the path that the message is moving and what's happening to modulate. So we've sent the message here to this raphe magnus, right? And now it is going to send modulation or chemical factors, or so endorphins, right? The endorphins that are coming from here, serotonin that's coming from here, right? To the dorsal horn to now respond to that noxious stimuli. And right, it's just going to go back the way that it came. The message goes back the way that it came. But that's what kind of provides us our own kind of little system of analgesia, right? But that's why there's, you know, everybody experiences pain so differently, because all of these responses, you know, they're requiring specific neurotransmitters here and here and here, and everybody has different levels of those. That's why some people suffer from depression, some people don't. I mean, it's not 100% the reason, but you get what I mean. And so people will experience pain differently. Does the raphe magnus make stuff or just take the serotonin? Both. It does both of those things. And the norepinephrine from the PHA, rostral pons, and send. Yes, both of those things. So the raphe magnus is responsible for a lot of serotonin creation, but it is also passing all of this stuff on from these other places and sending to the dorsal horn and then sending it out to the rest of the body. Let me go forward here. Sorry. So first order neurons, second order neurons, third order. I'm guessing this will definitely come up on your exam. Just understanding that we've actually talked about this process in kind of 3 separate sections, and that's all, what you really need to know to understand this. So the first order neurons are the ones that are receiving this noxious stimulus, and nociceptive neurons that are going from here to where they synapse into, in the dorsal horn, where they synapse to spinal neurons, okay? That's your first order neurons. Your second order neurons are basically your spinal thalamic tract. It's the spinal neurons that are transmitting from this synaptic cleft up to the thalamus. Nothing there. And then your third order neurons are going to be, now this gets a little bit confusing, but they transmit the signal or the message from the thalamus to the cortex where the pain is perceived. And again, we don't know exactly where. We do understand somewhere in the somatosensory cortex. It's so complicated, but the third order neurons are transmitting a message from the thalamus to the cortex, where then we have perception of the pain and then modulation after that. So hopefully that makes sense. All of this is using those A delta and C fibers and spinal thalamic tracts and so on that we talked about earlier. It's just, they just have separated them into these first, second, third order neurons for you. Okay, dermatomes. Do not freak out. You do not need to know all of these at all. You just need to understand the concept of how this works. So each spinal cord segment, each like dorsal root of a spinal nerve is going to innervate certain specific areas of the body. And you can see on this chart, so this side is giving you like the level of the body, right? Like the level of the nerve. So T9, T8, whatever. And this side is giving you the, like what nerves are innervating there. So the ulnar nerve, lateral cutaneous, patellar plexus. Don't worry, you don't need to know those. Basically what you need to know is that when those fibers come into the dorsal root there, they can overlap with each other, okay? And when that happens, so certain ones will overlap, other ones don't. So for example, I think on the next slide, I give you a good example of it here. So for example, the phrenic nerve originates in the diaphragm, right? And then it innervates, or it enters the spinal cord at C3 and C5. But your, I believe, left shoulder also innervates at, or both shoulders, at C3 and C5. And that is why you will get people who have abdominal issues. For example, this is a big one, cholecystitis, with pain referring to the shoulder, because the brain kind of mixes up the message, right? Like it's overlapping, it's going through the same spot in the dorsal horn, or the dorsal root, and sending that message up to the brain. And when the brain perceives it, it's just not clear necessarily where it's coming from. It's the same thing that happens when someone has an MI and they get a sore neck or a sore arm or what have you. This is pretty simple at this point because we've talked about a lot of this stuff already. You've got 3 different kind of levels of pain. You've got cutaneous, deep somatic, and visceral. We've talked already about what, when you see visceral, you're gonna think organs, so abdominal pain, chest pain, intestinal pain. If you get stuck on exams, sometimes you only have to know one thing, right? You know what visceral means. You know it means a pain in the organs. And most of you have had, I mean, you've had cramps, you've had, you've had issues with abdominal issues. You know that that's not necessarily a very localized pain. It's much more of just an abdominal pain. Yes, it might be in your right upper quadrant or so on, but it's not like pinprick or localized. And then your deep somatic, these are like your tissue injuries. You sprain your ankle, you pull a muscle, that kind of thing. And cutaneous, obviously, you guys know what cutaneous means. So this is superficial. This is I cut myself. So your stab wound would, yep, it would do a cutaneous, but it would also probably do a deep somatic because it's going to go through the, through the muscles as well. But then it's also, it might hit some organs. So you're going to have like all of these types of pain kind of happening at the same time. Neuropathic pain, we've talked about a little bit already. Again, this isn't about something outside of the body causing pain. This is about a problem with that path that we were just talking about, that path from the outside of the body, basically, or the sensory nerves to the brain and back. So if there's any kind of injury or dysfunction in those nerves, so things like MS, Guillain-Barré, those are kinds of things that will affect like the myelination, the communication between, you know, the outside of the body and the thalamus and the cortex. So yes, they can be caused by tissue injury, and they can also be caused by like a autoimmune disease or anything like that. Often you will have numbness, yes, paresthesia, which is just actually paresthesia. Oh, numbness, sorry, on one side, or difficulty moving on one side, a burning pain. So neuropathic pain is terrible. There is a difference. Like, I've actually personally experienced neuropathic pain, and I'll tell you, like, it is a totally different kind of pain than, you know, nociceptive pain. It's just, it's hard to even explain. Pain with light stroking of the skin, and this is because those, we talked earlier about those receptors are kind of like overreacting. You get like extreme pain on like nothing. If you've ever heard of trigeminal neuralgia, that's a really good example of this kind of neuropathic pain. So you remember from, I'm guessing, health assessment maybe, that your trigeminal nerve, one of your cranial nerves, right, it controls like a light, the light touch on the face. So it's not your facial nerve, right? It's just a light touch on your face. When you have trigeminal neuralgia, it is like excruciatingly painful for anyone to even like lightly touch your face. I also had a friend once who broke his back skiing and ended up with some of this kind of neuropathic pain as a result. And for weeks after, he couldn't have any sheets on him because the sheets touching his toes was sending this like excruciating pain into his body. And again, kind of goes along with this, you know, phantom pain without provocation. We kind of talked about this in one of the first slides. So shingles is another example. Right here, actually, I was talking about it. So sometimes neuropathic pain can be acute. So it's caused by some kind of short-term illness, disease, or injury. And shingles is a really good example of that. So yes, shingles is another example. Again, I tried to pick out the stuff from your module instead of like everything out of the textbook or everything that I've ever learned. I tried to stick to what was kind of in your module in terms of pain management. So again, it's rare for patients to lie about pain because it's subjective. Because of that, medications will work differently for different people. So you're going to have to adjust, and that's fine. One of the things that also comes up on exams all the time is that we want to quote unquote stay ahead of the pain. So we dose our meds around the clock, not PRN. So if somebody has whatever, they have some tissue injury, they're in the hospital, we're treating them. We're not giving them opioids only when they feel pain. We're giving them probably long or slow release, you know, every 12 hours or so on, and then fast release for breakout pain in between. You want to be ahead of that pain because it's so much easier to prevent further pain from occurring than it is to get rid of pain that's already started. This is a huge concept across the board for exam questions, and for nursing practice. You will be very, very grateful if you do this at work. If you're working on, I worked on a neurosurgery unit at one point, staying on top of those people's pain is Really important. It makes your day a lot easier so that you're not running all around. Anyway, the goal of management obviously is to alleviate the pain and restore function. So analgesics, just for fun, analgesic is pain. A before it means no pain. So that's what we're trying to remove, the pain. Multimodal is really, really common. So people will be on, gabapentin, and they'll be taking Tylenol, and they'll be on opioids, and it's sometimes a little bit scary and overwhelming, but it's very, very typical for people to be using more than one pain medication at a time. This is really important. This is what we want our medications to do. We want it to be, yes, effective, non-addicting, affordable. This is more, I mean, most of us are covered in Canada, right? So it's not as important. But anyway, and have minimal side effects or adverse effects. You guys know from your talk about opioids, like how many side effects they have. So they really don't hit very many of these categories, other than they're super effective for most people. This is just, I liked this picture. I think it was in your module, and it just kind of showed where some of these analgesics work in that kind of path through. I liked it because it's the NSAID here that's blocking that COX-2 that's coming from the arachidonic acid that we talked about last week. It talks about, local anesthetics like lidocaine working here, and opioid agonists working in this synaptic cleft. It's just, I liked it. I don't think you necessarily need to like memorize that or know where each one is working, but understanding that they do all work in different places. So always on exams, we try to treat our pain non-pharmacologically first. So we're always going to use distraction techniques, cognitive behavior techniques, like these biofeedback and so on. I would take some time and just kind of go through this slide, because if I were a prof, I would definitely pull some questions off of this, just, how these things work, or what should you do first, one of those what should you do first things for pain or whatever. I would pull some stuff off there, but it's nothing that you guys can't read over and just understand and be good with fairly quickly. So Tylenol, this is it's an alternative to NSAIDs. Often we give them both at the same time, or we alternate between them, NSAID, Tylenol. In the ER, it's really fun because we have directives, which means that I can, if a patient comes in and they're complaining of whatever pain, I can give all that without an order, which is really nice, because sometimes it takes the doctor like 3 hours to get there and the person's in pain, right? And I haven't necessarily done the distraction and relaxation stuff. I'm like, here, take some Tylenol and ibuprofen. Anyway, so it has very strong antipyretic effects, and we know that. You guys know that from real life. Okay, let's break that down. Anti is against or whatever. Pyretic is heat, fire, and in this case, fever. Okay, so it has very strong antipyretic properties because it inhibits that COX mechanism right in the hypothalamus, but not in the periphery. So it's not a really great anti-inflammatory because it's not inhibiting those like prostaglandins and what have you here, where it's just been activated and stimulated and it's releasing here. It's actually working on these prostaglandins here. This is where Tylenol or acetaminophen is going to do most of its work. And so that's why it has such strong antipyretic properties. And that's also why we don't have as many anti-inflammatory properties, and why there isn't a risk of GI bleed. There are very, very few adverse effects with Tylenol. You guys know that. Normal doses, high doses and long-term doses, yes. Hepatotoxicity is a big thing, comes up on lots of tests. In real life, you do not give more than 4,000 milligrams a day of Tylenol, and you have to be really careful because medications like Percocet will come with 325 milligrams of Tylenol, 5 milligrams of Oxy, and you have to make sure that you're counting that because you really, it will increase your ALT, it will damage your liver. But that's really something that happens like very high doses and long term. All those new studies are showing that it can affect earlier than we thought. And cannabis, it's used mostly for chronic pain, especially cancer. Used in prevention of osteoporosis, and I'm hoping that I don't know the mechanism behind this either. It's just something that I maybe try to remember because it's on this. It was in your notes. Okay, so yes, it's made up of THC and all of these cannabinoids. CBD, these are actually cannabinoids as well. There are different strains with varying strengths and effects. Many of you will probably know all of this and have used cannabis on your own, and so this is all review for you. They want you to understand the difference between cannabinoids and CBD. So cannabis is any raw thing that is made from the leaves or the flowers of the cannabis plant. There's nothing added or taken out. Sorry. The cannabinoids are the compounds that are found in the sativa plant, on like the little hairs. When they say lipophilic here, so this is how I would break that down if I didn't know what the word meant. Lipo, we know, always means fat or lipid, right? And philic is like they like it. So this actually means that they dissolve easily or combine easily with fats or lipids. These cannabinoids, yes, of course, they interact with the endocannabinoid system. We'll talk about that in a second. And then CBD is just a type of cannabinoid that will also works with endogenous cannabinoids. So I think the next slide explains the endogenous stuff, and I just don't want to go. So basically, we have a cannabinoid kind of system, endogenous cannabinoids in our body. It can also be called the endocannabinoid system, right? And those endogenous cannabinoids bind to receptors, and they affect sleep, they affect mood, mood, appetite, memory, and sleep. You will understand these things if you've ever actually just even watched TV. I think what's really important, what really is happening here that you need to understand the difference is the difference between THC and CBD right here. So there are two inside in our bodies, there are two main receptors, so CB1 and CB2, okay? THC will bind to both of these and will kind of mimic the endocannabinoid response. So, but it does so at a multiplied level. So it will affect your mood, your memory, it will affect pain, and it definitely will have psychotropic effects. And that's because it's binding to these receptors at a higher level than your normal endocannabinoid system would. Your CBD actually just modulates the effects of the endocannabinoids in your system. And I just want to let you guys, I mean, this stuff is very, this hasn't been studied a lot. So I've done quite a bit of research actually on cannabis and treatment and what have you. And this isn't necessarily 100% known at this point, but for the course, just make sure that you know, in case there's a question. They want you to know that it's a receptor antagonist and that it modulates endocannabinoids. So it modulates the cannabinoids that are already in our body instead of binding to the receptors and creating this kind of like over response. Okay, those are I think really the only important things that you need to know about like the difference between the two. This is pretty obvious, but I'll go through it in case anybody hasn't ever had THC in their system. The THC, yes, is responsible for most of the pharmacological effect. It has that high. It's what gives you the analgesic, inflammatory response. All of these kind of responses here have to do with the THC. THC is actually a fairly potent vasodilator, and that's why you have it actually really vasodilates in the eyes, and that's why you end up getting those kind of red eyes. And yes, we all know it can induce anxiety or paranoia. Um, hopefully, well, it can be vaped, smoked, ingested through edibles. It can be used topicals or tea. And since I think we're on our second last slide, I will just tell you a story because it's funny. One of my best friends works in Grand River in the mental health emergency. And since COVID has started, first of all, since COVID has since March, she said over half the patients are mental health patients that come in because people are just breaking down, right? They don't have their supports. They're stopping, not taking their medications and so on. But she also said she was really shocked at the amount of people coming in with in a psychotic state, their first ever psychotic episode with no history of mental illness. And she said we do blood work, and all that comes back is cannabis. They've basically overdosed on cannabis, which, we think is impossible. But it really, 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 and I've seen this in the ER in my hospital as well. It can have a huge, huge effect on treating those kinds of like psychotic episodes if you're prone to them and if you take too much. The takeaway from this slide is just understand that we shouldn't be using it during brain development. So the hippocampus is responsible for processing information, especially your memory. And as we age, we lose neurons in the hippocampus. That's why it's harder for old people like me to learn new information, and why my kids can learn anything because they're like little sponges. Chronic marijuana use, and especially chronic marijuana use during your developing years, can actually cause that neuron loss earlier. I think we probably all know someone, we've maybe seen that happen. And then gabapentin is usually, yes, it's used as adjuvant therapy. Adjuvant means we're adding it to something else. So we're already taking, like I said before, you're taking opioids and Tylenol or whatever, you're also taking gabapentin. It is mostly used for neuropathic pain. I don't know if that's on this slide. Yep, it is. So in the hospital or in long-term care or wherever, you're going to be, if you give Lyrica, which is pregabalin or gabapentin, it's mostly for neuropathic pain. But we will use it for some of these other as well, like as an adjuvant therapy. Does cause drowsiness and dizziness, but nowhere near what an opioid would cause in terms of drowsiness.